Okay, good morning, everybody. I'm filling in for Devin this morning. And so we'll get started. Hopefully the Zoom people can hear us, and if not, let Jessica know. So our speaker today is Ms. Brittany Hylander, one of our interns over at the GREC. She will be talking about Healthy Aging Promotion Program for Elders in South Florida, the HAPPE-SoFLo. HAPPE-SoFLo lessons from community outreach during the COVID-19 pandemic. Our next Grand Rounds is on April 18th with Doctors Danielle Fixon and Sunny Limber doing their annual new drug and device update, always a crowd pleaser. Our next journal club will be on the 11th over Zoom with Emily Stauffer and Hillary Lum. Following today's Grand Rounds, you will receive an email with a link to the recording of today's presentation with a link to the online evaluation. So please do that, and please submit questions in the chat or Q&A boxes anytime during this presentation. So Brittany Hylander is the current geropsychology intern at the Rocky Mountain Regional VA in Aurora. Upon completion of her internship year, she will graduate this June with her PsyD in clinical psychology and has recently accepted a geropsychology postdoctoral resident position at the VA Bedford Health System in Bedford, Massachusetts. Brittany's clinical passions include providing psychoeducation to older adult communities about healthy aging, as well as assessing, diagnosing, and supporting older patients and their support systems when there are concerns with physical and/or cognitive decline. Brittany also has clinical interest in assisting organizations in becoming culturally competent and inclusive to provide safe spaces for individuals from marginalized communities. Welcome, Ms. Hylander.
All right, good morning, everybody. My name is Brittany Hylander. As I was addressed, thank you. And today I'm going to be presenting on the Healthy Aging Promotion Program for Elders in South Florida, HAPPE-SoFLo, lessons from community outreach during the COVID-19 pandemic. So the main objectives that I want to hit on with you guys today is first just setting the scene in which this intervention took place, when and where, then provide some conceptual background of this intervention, introduce the key players that were involved, as well as overview the intervention itself, talk about barriers and limitations that we recognize post-intervention, and then recommendations for future directions. So I first want to turn the clock back a little bit and set the scene for us. March 11, 2020, the World Health Organization declared COVID-19 as a pandemic after more than 118,000 cases were posted in 114 countries and 4,291 deaths and counting. This, as we know, disrupted and impacted all levels of society, from our daily life to our healthcare systems. In efforts to slow down that spread of infection of COVID-19, put in mandates such as mask wearing, social distancing, frequent testing, and quarantining became our new normal. Earlier in research, they also voiced concern over the impact of protective measures and higher levels of restriction, such as stay-at-home orders and lockdown mandates, and how that would impact levels of loneliness and other mental health consequences, particularly in our historically overlooked populations, such as our older adults. This pandemic also complicated existing barriers to staying socially connected and mentally healthy in later life, things that we already knew from the start, such as role transitions, loss, health decline, and other loss of resources as we age, such as limited accessibility to transportation, accessibility to internet and technology access, as well as community-based group activities. Despite heightened community concern for the well-being of our older adults, and because of their susceptibility to contracting COVID-19, social isolation occurred in these stay-at-home ordered mandates that resulted in emotional distress, avoidant behaviors, increased risk for elder abuse, and rapid cognitive decline. And this was even more so in those that were a part of other disadvantaged statuses, such as ethnic racial minorities, low socioeconomic status, and LGBTQ+ groups. So in order to address the mental health crisis as a result of the pandemic, multiple calls to action and initiatives were made to improve mental health care, research, and delivery of resources to ensure to mitigate as many disparities as possible and increase access for our vulnerable populations. There are many reactions by providers and community organizations. One early study that came out from APA talked about how to protect patients and their practice. So altering practice policies such as cancellation policies. So if your providers or their patients were exposed to COVID, maybe having more flexibility with cancellation policies. Exploring and then ultimately moving to teletherapy methods for providing services and just being aware of what their county, what their state allowed for when their jurisdictions. I also really appreciated an article by Koplovich et al. This was initiatives and strategies that they reflected on that were occurring early on within the pandemic, as early as April of 2020, that were already occurring within the US. And then they talked about how they could be optimized even more so as the healthcare system continued to change and us reacting to it because of COVID. So within this paper, they mainly focus on the serious mental illness population, which is also another vulnerable population. But the challenges that this population face, such as needing to go to the ER frequently, food, water, financial insecurities, homelessness, all of those are challenges that other vulnerable populations are likely to experience as well. And so the continuum of services that they put up within this paper, they could easily be transferable amongst other vulnerable populations. So things that they suggested of like variety of modalities and providing services, hands-on decks approach where we're pulling in family members to provide support for those vulnerable individuals, having staff members also do welfare checks to check in with these populations, providers augmenting their time with patients. So instead of maybe an hour-long session, they're doing shorter sessions more frequently to have more touch points. Also shifting priority of care from skills to more what support do you need right now? And then if it was in their scope, providing medical management as well. And so even with suggested strategies and great papers like this that came out earlier within the pandemic, there was still a lack of clear guidance on how to conduct and implement initiatives to support our vulnerable populations during the COVID-19 pandemic, especially in regards to community outreach. So for my dissertation, I created a step-by-step guide on creating a community outreach programming that promoted psychoeducation as well as emotional and social support for the older adult population within the context of the COVID-19 pandemic, but that could easily be transferable now that we are post-pandemic. So now that we understand kind of the context in which this occurred, I want to dig into the conceptual background of HAPPE-SoFLo. So the development of this intervention was guided by the central principles of community-based participatory research, or CBPR. And this model really talks about how to collaboratively and equitably work with community partners in determining their identity, their strengths, and their needs. Just a little bit of background on how this model was developed. It really was trying to refocus research after randomized clinical trials became this golden standard. So in '98, Israel et al. Found that they felt that while public health was examining environmental and social determinants of health and involved the public identifying and addressing public health issues, that this push for RTCs more recently tended to stress an individual model and focus rather than social and environmental risk factors. And so while they weren't knocking our CTs at all, they noted how this can create distance between researchers and providers and the interventions that they are providing to the public. And this distinction can tend to obscure contributions of social and environmental factors to health that can create this disconnect between knowledge and, again, the intervention or policy putting in place, and then further impacting marginalized communities. Since its development, there have been many names to this research model. Earlier within development, community-based research was often used, but over the time they have added this participatory piece to it, and there's good reason for that. They really wanted to make sure that there was a distinction and an emphasis on this research not just occurring within the community as a setting, as a place, but that the community is a part of the research process and they are participating and they are adding their value, their assets within the research process as a whole. So the primary aims with CBPR is really to increase knowledge and understanding of a given phenomenon, and integrate that knowledge into an intervention or a policy to improve health and quality of life for their community members. So as I mentioned, HAPPE-SoFLo is heavily influenced by the principles of this conceptual model. And so I'll go briefly through these key principles and I'll keep highlighting them throughout of how we implemented it through the intervention. So first is just recognizing the community as a unit of identity. We want to look at the community as a whole and how they're connected. So is it through norms? Is it through values? Or even just a geographical location? We also want to build on their strengths and their resources, facilitate collaborative and equitable partnership in all phases of the research project. And this should empower the community through power sharing, and it should attend to any social inequities. So researchers and providers should understand any inequities that occurred between them and the community. And then in being able to address that, they should help build that relationship off of mutual respect. And so the community should be empowered with that decision-making, sharing of resources and information, and having them involved through the process throughout. Should also be fostering co-learning and capacity building amongst all partners, so exchanging skills and knowledge and seeing who of the all members that are involved in this partnership are bringing their own expertise to the table. Also should be integrating this knowledge learned and the intervention should be mutual for all partners involved. We should also be focusing on the local relevance of public health problems and on an ecological perspective that attends to the multiple determinants of health. So we should be paying attention not to only the individual community members, their families and their social networks, but also the bigger picture, the community as a whole and within society. And looking at those multiple determinants of health, such as culture, biological background, social, economical, and physical environment. This process should be cyclical and iterative, where it touches on all aspects of research design and process. Any findings should be disseminated to all partners, and that knowledge should be useful and accessible. And additionally, this should be a long-term process that is sustainable. It should not be for a single research project or a funding period. So now that we have our foundation of the intervention, I want to move into the who was involved. So first part of CBPR model is to have a partnership. If you don't have a partnership, you can't move anywhere from here. So developing a partnership is the first and most important step. Community is where there is a shared identity between individuals. And so when there is a partnership made, it should reflect the culture of the community and their knowledge and their assets and resources. Partnerships obviously are easier to start when there is already a positive connection, but it can be started from scratch. You should always be checking in with your partner of who they are, getting a good background, and then how you can both support and share information and resources with one another. So the key players within this intervention was first the providers, which is Nova Southeastern University's Counseling Center for Older Adults, also known as NACOA. This was an outpatient psychological service center really focused on working with adults that were 55 plus, interested in developing more effective ways to manage difficult situations and life challenges, hopefully with the works of improving their quality of life and overall functioning. And then our community partner was South Florida Institute on Aging, also known as SOFIA. This was a woman-led grassroots nonprofit organization within South Florida who really focused on providing equitable and quality services to the lives of aging community members and their families within South Florida, specifically Broward County. And so within Sophia's major organization, there were 5 sub-programs that we worked closely with. I'm not going to dig into them currently, but if there's any questions about them in the Q&A, we can definitely touch on those later on. So luckily, we had already worked previously on a project with Sophia in the past, and we already had a positive relationship. So we didn't have to start from scratch, which was great. And we were able to build upon that already, that positive connection to develop and implement HAPPE-SoFLo. So now that we know who was involved, I wanted to start digging into this intervention itself. So this intervention had 5 phases. I'm going to go and touch on in specific detail each phase of this intervention, and then we'll dig into barriers and limitations later. So phase one was conducting a comprehensive needs assessment. This is really a structured approach to understanding the identity, the strengths, the assets, and the needs of community partners. It is designed to be collaborative, interactive, productive, and promoting a maximum understanding of what support is needed within the time requirement of 12 months due to the rotation of practicum students within NACOA who were the providers. We did ensure that CBPR principles were implemented throughout this phase, first acknowledging the community as an identity. Before we even came to this needs assessment, we knew that we were going to be having a majority older adult population. They were geographically located within Broward County of South Florida, and that they had this altruistic aspect of, because they were volunteers and community members that were trying to support other older adults within the community, or that they just wanted to be active, a part of their community and being a part of the SoFIA organization. Also, we all knew that they were experiencing COVID-19 challenges, just like we were. But while we came in with these preconceived notions, we cannot provide adequate services if there's a lack of understanding of who our organization is, and kind of asking those questions and understanding their intersections of identity. So through this needs assessment, we gain knowledge around their demographics of the subgroups within their organization. So ethnic, racial makeup and gender, varying challenges with mobility and functionality, their caregiver status, if they had any food, housing, or financial insecurities, access to technology. We also built upon their strengths and resources, under really asking them what they had within themselves and how they were moving through this COVID-19 pandemic. We also facilitated a collaborative and equitable partnership in having this back and forth with this initial interview. And we really focused on their public health problems, what challenges and gaps in services were they experiencing on an ecological perspective, and touching on multiple determinants of health. And so we really dug into their primary goals as an organization, their values, who were the stakeholders, shareholders, their structure, their strengths, their gaps in service, as well as how they were handling the COVID-19 pandemic. And so all of this allowed for maximizing the potential for a successful outcome later on. So here are some recommended questions for the community outreach needs assessment, and the questions that we asked in this initial interview. Again, touching on what their goals were, programs that were delivered, community members they were serving, their needs, their gaps, how they were dealing with the pandemic. Also, a question I thought was really important, especially at this time, was how had recent anti-racism and social justice movement impacted their community members because of the diversity of the community members in this organization. After we conduct a comprehensive needs assessment, we need to determine what are the potential feasible and beneficial support services that we could offer as providers. So in doing that, we use the needs assessment really as a guide to help us figure out what we could propose to SoFIA. We've started to create this list of services really with the background of wanting it to be beneficial to the community partner, right? Why provide services if they're not going to benefit our partner? And we wanted to make sure that this fell into the scope of the personnel's abilities and resources. And this isn't just as providers ourselves, but also for the community partner. So when we take from the perspective of the provider, we had to recognize that what resources were available and at our disposal. Proposing the potential services to community members where that weren't available and can set providers up for failure, because as they may overestimate or underestimate the services that they could potentially provide, and that is even more so strained in a time-limited intervention. And so falling short on services will often decrease the impact and the benefit of the community, and it can also impact future collaborations, right? If you fell through on initial intervention, then why would I want to have a collaboration later on? So given that HAPPE-SoFLo was set within a small community-based clinic, staffed by 7 psychology graduate students, and under the supervision of 1 clinical licensed psychologist, there were limitations to the resources we had and the services that we could provide. And then for our community partner, from their perspective, we had to understand what resources were available to them. So then the partner could be able to utilize those together and provide the most optimal services as much as possible that were useful, and we didn't want them to be redundant. Lacking that knowledge can add stress, especially when there is a time constraint, and then this could also impact the quality of services provided. I did want to note that it is important to understand that the needs of the community and the resources of the providers or the community could change at any time during this intervention. This is something that we understood later as we kind of looked over the intervention period. And so I'll come and talk about that a little bit more later on, but just something to keep in mind. And so this also emphasizes the significance of providers maintaining open communication with community partners to ensure that the most optimal services are being provided. Additionally, we wanted to make sure that the services provided were safe and practical for our older community members. As I stated, even prior to the needs assessment, we knew that age was going to be a big diversity factor that we needed to account for. So part of that, we wanted to make sure that our older community members would be able to participate no matter their technological access. And we also wanted to make sure that the areas that we touched on with this community were how to age healthfully, and that can be increasing their awareness and knowledge or providing support and assessment. So after taking all these considerations into play, we came up with the following services to provide or to propose to Sophia. Psychoeducation, and this was remote video and phone support and speaker series or remote lunch and learn specifically for their staff and directors. Assessment services, so remote psychological and cognitive screenings. Specialized counseling services for older adults, so psychological services or consultation services, as well as data analysis. So sub-programs within this organization needed support or had a question that they wanted to be answered or evaluation, we could provide support in that area. Now that we had our proposed services, we actually had to tell and propose this to our community partner and get their feedback and thoughts on what may be most beneficial for them and their members. So we first met with Sophia program leaders, directors, and staff with our proposed services, and we had a discussion on what would this look like, how frequently would this occur, and what would serve best for them and their community members and volunteers. We also held several focus groups of community members and volunteers to see what different, if we gave presentations, what would the topics be that you would find of most help and usefulness during this time? What other services could be of benefit for you for ones that we proposed? And so in proposing potential services, us as providers acknowledge the expertise of the community partner and about what they knew about themselves and about the resources they had and how best to serve their community members. So we allowed this space for clarification on what, again, the services would look like and how they would be implemented. And so in doing so, all parties were involved and came together to agree upon what would be of most benefit to the community members. And we continue to implement CBPR principles like facilitating that collaborative and equitable partnership, fostering co-learning and capacity building, integrating our knowledge with intervention for the mutual benefit of both partners, and again, focusing on public health problems from an ecological perspective with multiple determinants of health. After these discussions, we came out with a finalized list of remote psychological presentations for both staff and community members and volunteers, remote cognitive and mood screenings, as well as consultation and therapeutics service referrals, and assisting Sophia's sub-program in becoming evidence-based. So we have our list of services that we want to move forward with. Now it's actually putting them into practice. So our fourth phase was in creation and administration of these customized services. So as we had done before, we were implementing our community partner in all aspects of our intervention. We began the preparation and implementation of these services with the involvement of Sophia. And this was done through direct communication where we had meetings and we had email correspondence and back and forth on how we wanted to go about all of our services. And we also used our feedback as an involvement within Sophia and how we could tailor our services as best as possible for them to be useful. Our feedback was both formal and informal. So formally, we had surveys within subgroups that were provided post-session. So after initial services were started, we were able to tailor and shift gears if there was any feedback that would be more beneficial for the community members. And also informal. So if someone stayed behind and gave suggestion or felt that something could be altered, then we also took that information and altered our services from there. So now I'm gonna overview the services one by one and how we implemented that within HAPPE-SoFLo. So first were the psychoeducational talks. These were 45-minute dynamic presentations covering a variety of topics. I say dynamic because we really wanted to allow space not only for psychoeducation around healthy aging and other topics for our older adult community members, but we were all socially isolated in the height of COVID. We wanted to make sure it was, we had a lively group, and so we wanted to allow for interactions and reactions and questions and answers. So within these presentations, just some of the topics that we covered were signs of healthy aging, stigma around mental illness, depression and anxiety in later age, dementia, and then things around the physical health, nutrition and exercise, COVID-19, and the importance of telemedicine. We made sure within these presentations to find different ways to acknowledge diverse identities as well, because we knew the makeup of our community partner and their volunteers. So for example, we highlighted how being a member of different communities and groups like ethnic, racial minorities, LGBTQ+, low socioeconomic status, or being an older adult can impact mental health, well-being, even access to care and COVID-19 in different ways. So throughout this intervention period, we ended up administering 23 psychoeducational presentations to 5 different subgroups that we worked closely with within this Sophia organization. Again, we ensured that there was collaboration throughout, from the content that we put out, the delivery of the programming, the accessibility of our presentations, and how useful it was to staff and our community volunteers. Again, we were eliciting feedback, so we wanted to make sure that this was done both, again, formally, informally. Sub-programs had their own post-session survey where we were able to collect data from, and we welcomed informal feedback from members or staff and directors. I remember in one of the first talks that I provided, one of the directors had stayed after and made a note that the level that information was provided should be altered just to ensure it was accessible to everyone, because we had such a diverse volunteer base. And with different levels of educational attainment, we wanted to make sure that the information was accessible and understood by everybody, so that alteration was made and we didn't have any issues for our later presentations. So again, how we're involving our community members, taking that feedback to make sure that all services were accessible for everyone. For our next service that we provided, we administered cognitive and emotional screenings and provided consultation services. So volunteers were notified by their director throughout the sub-programs of the opportunities to receive free cognitive and emotional screenings from NACOA psychology trainees. Once interested members information was provided to the providers, they were contacted and scheduled for individual appointments. We then administered cognitive and mood screeners during those appointments, specifically the GDS, the GAI, the MOCA Blind, and the PWB. After those assessments were scored and examined for accuracy, then we had feedback sessions that were scheduled with those community members, and we went over their results and we provided any recommendations and referrals if we felt that there was some cognitive changes that were going on, more neuropsychological testing, and provided referrals there. Or if there was mood concerns, providing consultation and referrals to getting therapeutic services and support. I will note that throughout this year period, we only were able to assess 3 community members. I am going to touch on within our barriers and limitations why we think that is and how for future directions this can be improved upon if this is replicated. And the last service that we provided was assisting the sub-program within SoFIA of becoming evidence-based. We first wanted to determine this sub-program's operational status. Where were they at in becoming evidence-based of their primary goal? And we found out they were evidence-informed according to their federal funder, AmeriCorps, which was under a bigger umbrella of the Corporation of National and Community Services, and that their next goal was in moving toward evidence-based with further evaluation. So to help them do this, we had to do some data collection. First, we just did some basic research on who is this program, what's their history, what's their background, how do they go about with evaluations and providing support services. And then we did some more research on their federal funder of AmeriCorps and the Corporation for National and Community Services. We then started to look at and model after other evidence-based programs within these other federal funding umbrellas, seeing what were they doing to be evidence-based, what are evaluations and areas of support and guidance that they were using to get to this evidence-based status, and how can we model it with this sub-program specifically. And then we began to collect program materials. So we started to look at their curriculum, their demographics of their volunteers and community members. What evaluations were they using? How much data did they have? And how can we collect that and put that forward to help them in becoming evidence-based? So after all of this, we first developed a detailed checklist. This was first had an outline of what their federal funded standards were and their expectations for becoming evidence-based. We then asked our community partner, the specific sub-program, specific questions regarding their program, data collection, how they've been doing that over the years, and previous program evaluations that they had. And then we gave a detailed checklist of how to become evidence-based, other data that would need to be collected, how we could analyze it, and moving forward. I will note that there were barriers to proceed forward with this service. We had to stop at this detailed checklist. We came into a lot of limitations and barriers, and that I'll touch on a little bit more later in this presentation. But despite that, we still continue to implement CBPR principles and facilitating our partnership, co-learning and capacity building, integrating knowledge and for the benefit of both partners, as well as integrating that cyclical iterative cycle of the process of the research design and disseminating our findings, research that we did, and creating a checklist for this program. So we implemented all of these services. Now we had to understand, was it actually beneficial? Was it useful for this program and this organization? And then once we had those findings, we disseminated it back to the community. So first we had to, again, determine, was this actually beneficial? So we conducted an outcome assessment, which is really evaluating and determining intermediate outcomes and impact objectives. We wanted this again to be collaborative and productive, really promoting the understanding of if we met the community's needs. And we also wanted to see how effective was our collaboration, right? This was a partnership, and did we have good communication? Was this an effective partnership and collaboration again, so this can be moved forward into future partnerships and projects? So our final outcome assessment report, we really hope to have the needs assessment itself from where we started, what we were hoping to reach with them, determine and proposal of support services that we ended up agreeing upon, administration of services, how that was done, then evaluating how HAPPE-SoFLo benefited the community, and then listing barriers, limitations, and future directions. So we first had to compile data from both sides of the partnership. So we pulled together presentation records, numbers of volunteers that were assessed and their information, informal feedback that was provided throughout this year, survey results both from the sub-program itself and post-intervention surveys that NACOA had pushed out to the community partners, as well as program directors' own service utilization records. So the data was analyzed and determined if the intervention improved volunteers in specifically 3 areas: their knowledge of aging healthily, their level of socialization, and their overall well-being. And so from these results, we found, first looking at the sub-programs members post-intervention surveys that community members had put up their formal feedback. 73% reported feeling more connected to their family, to their friends, and to their community. They felt more optimistic about their future, and they felt much more confident about living independently. 82% reported an increase in their understanding of dementia and Alzheimer's. They felt more comfortable with telemedicine, and they felt more comfortable with accessing COVID-19 information and in dealing with the stress that was related to COVID-19 and the pandemic. And 100% of participants felt more confident accessing health and wellness resources as a whole. And they felt that the instructors that were providing these psychoeducational talks specifically exceeded their expectations, and that they deemed the courses as being really useful. One quote by a volunteer that noted the most important benefit that they experienced as a part of our services was being able to share experiences with other seniors during this pandemic with conversations and laughter. From staff post-intervention surveys that we provided out to staff and directors, they reported no identified barriers to any of the services that we provided. They rated the psychoeducational talks of all the services as the most beneficial. They really felt that the psychoeducational talks were the most beneficial because it provided this space for their community members to ask questions and become informed on a variety of psychological topics and to touch on their overall well-being. One note that came out within one of our surveys was from one of our staff members was the presentations made a tremendous impact on our volunteers and has paved a path for creating a healthy relationship with mental hygiene. The presenters were knowledgeable and enthusiastic, which was felt through Zoom meetings. We are appreciative of this opportunity. And some feedback from Sophia's director to NACOA's director outside of the survey after the intervention was said and done was I wanted to take a moment to express to you the pleasure it's been in having psychology trainees present for our volunteers. They've made such an impact and helped me in my goal to remove stigma and promote knowledge, resources, and skills to address mental health in the older adult community. Our volunteers were able to open up about their struggles and those they see in their clients. They were grateful and excited to learn. I look forward to having them present again. So overall, the results from this outcome assessment were very positive. Psychoeducational talks were listed as the most important, most beneficial for both community members community members and volunteers, as well as staff and directors that were a part of this intervention. So overall, really great results. After this outcome assessment was compiled and put together, we disseminated it back to the directors, to the staff, and community members that were interested. That being said, with all that positive feedback, there were still barriers and limitations to this intervention that we definitely saw and took forward with us. So while we experience barriers and limitation, we do see them as growth areas and ways that we can understand this intervention better and how we can improve it. As you can imagine, COVID-19 was a huge barrier, despite us understanding this being a context that we were in and how we could provide services in this environment. It required social distancing and remote services throughout. It required internet access of our services or telephone access to access our psychoeducational talks or other services. As we kind of have seen throughout research from the time of the pandemic, it is likely that online services allowed more access to individuals that maybe wouldn't have been able to come in person if our services were done one-on-one, face-to-face. And so while allowed access in those areas, we understand that internet accessibility is a challenge for a lot of populations. And so some individuals that might have been more of a barrier. COVID-19 also served as a major barrier for helping the sub-program in becoming evidence-based. We found out as we started doing more research and started to collect program materials, all of their records were on paper. So that would have required for us to go in person. And while there was conversation of PPE and how we could do that safely just for us as clinical trainees and for the staff, we felt that it would be inappropriate to put us at risk because, again, this was at the height of the pandemic. A vaccine hadn't been produced yet. And so that put a big limitation on that service specifically. Another area that we found a barrier and a limitation was just availability conflict. The providers from NACOA were doctoral trainees that were not only providing services through the HAPPE-SoFLo intervention, but they also were carrying a load of cases within NACOA, and then they were full-time graduate students. So we had a very constrained schedule of what availability we could provide. And then this also was challenging to line up with the availability of staff and directors that were very busy themselves, dealing with community members and volunteers that they were trying to support through a pandemic. So trying to line up our availability was very challenging and created a lot of limitations. That being said, organizational change within the intervention period also impacted availability conflict. So it wasn't known at the start of the intervention, but until we were underway a few months in, where there were major changes within the organization's hierarchy, and that further impacted staff and directors' availability as well as their resources. So with some projects like the psychoeducational talks tend to be really robust and really beneficial, and we can do a lot with. Other projects weren't as robust, and it came into this hierarchical change. Looking back, we wonder if we should have asked questions in our needs assessment about possible organizational change and what that would look like, how that could impact resources. But I wonder even if the staff had that insight at that early point within this intervention period, because it seemed to be a very quick change in the middle of our time together. So that was an aspect that, again, created barriers for us. Another was the time constraint. Again, I said CBPR principles influence this intervention. One of those principles is ensuring that this isn't just an intervention period, that this should be sustainable. Because NACOA's trainees being within this practicum for 1 year, we were limited to 12 months. So that would be an area for future directions and being able to carry this on through other cohorts and make it more sustainable. And then with availability conflict, hierarchical changes in the organization, that further made it challenging with such a time constrained and time limited intervention. Next, there was a lack of clear communication specifically for the assessment and consultation service delivery for our community members. Again, we were only able to assess 3 members throughout a whole year. Looking back, we figured that it would have been more beneficial for us as NACOA providers to show up with program directors and answer any questions and provide more understanding around what were these cognitive screenings that we were going to do and mood assessments and consultation services that we were going to provide. That could help dispel myths, answer any questions that they had, and increase comfort putting kind of a face to a name of or face to a service that was being provided. Because what we found was by the time providers were reaching out to those community members that said that they were interested, they couldn't remember who we were. Who are you with again? What services are you providing? Wait, where's my information going? So being able to have that connection earlier on, that was a limitation for us. And so moving forward and making sure that we kind of put our face to that service would be really important. And then finally, administering surveys for community members and volunteers following each service. One of the sub-programs, just a part of their programming, they already had surveys in place, which we pulled information from. And then at the end of our intervention period, I created a survey for all directors and staff to be able to access and provide us feedback information. But looking back to have even more data to support our outcome assessment and give us an idea on how beneficial our services were, it would have been really great to have a survey for our community members and our staff and directors after each service was provided. So before I leave you guys today, I just want to provide some recommendations for future community outreach projects. Hindsight is 2020, and yes, that is a pun that I put in here for. During the COVID-19 pandemic, NACOA was not the alone service provider to promote services for vulnerable populations in a similar way to this HAPPE-SoFLo intervention. So I pulled some really great studies that have come out over the years and how they reacted in providing support services to vulnerable populations during this pandemic time. One was from Sherpas et al. That developed a manuscript outlining a model of a partnership between a long-term assisted living facility and clinical training programs to meet community needs and educations for older adults. Another was by Glover et al. That outlined a co-designed process between health providers and older adults and their caregivers, and creating a document to help providers support these families during the pandemic. Roth, Wu, and Doinger White explored ways that immigrant serving organizations made accommodations during the pandemic for their constituents. And LaPerry et al. Released a study in 2023 exploring how municipalities and nonprofit organizations responded to the pandemic in regarding to service delivery and programming for people with disabilities. So some recommendations from HAPPE-SoFLo intervention and these interventions that I list here. One is just community providers should know and connect with their community partners. Sherpas et al. Talked about how faculty knew that they had specialized trainees to work with older adults, and knew that there were needs in the community for older adults that were struggling during the COVID-19 pandemic. And even a CEO of the assisted living had known that his older adults within his community were struggling, and how they could work together to provide gaps in service and provide support to those vulnerable populations. Roth, Wu, and Doinger White talked about how within the pandemic, they noticed that mainstream organizations and even the government realized that there was a lack of capacity and trust with immigrant populations. And so by partnering with immigrant serving organizations, they were able to mainstream those services because there was already a working relationship there with that population. Collaboration requires consistent communication. LaPerry et al. Discussed how throughout their whole research study that they ongoingly consulted with their community partners, ensuring that services were being met and meeting their needs, and really supportive of the gaps that they had. Glover et al. Consulted with regional working groups of Alzheimer's associations and older adults and their family members that were providing support, long-term care facilities. And they worked together from phase one throughout their intervention of building this document for providers to provide support to these vulnerable populations, ensuring that all needs were talked about and all expertise were brought in for this intervention. Adaptation is necessary. I think we learned this very well on our own within COVID, that we need to be flexible. And while all of these interventions, as well as HAPPE-SoFLo, had a lot in common, one was being flexible and being able to adapt. LaPerry et al. Mentioned that they recognize that we can't create new services. We need to adapt them to being more accessible, such as being online. And even then, when things couldn't be adapted, how can we reach out and partner with other groups within the community to provide those support services? And then service provision should be happening at all levels for all members. Communities come in all different shapes and sizes and hierarchies and forms. And while getting direct services to those that are most in need is very important, we also should be providing support and education to those at top. So then that information and support can flow top down, and vice versa. So Glover et al. Addressed within their presentation that though the intervention was for providers and ended up being a guidance for providers, they used older adults and their families to support that understanding, and it was to help support those vulnerable populations. So that service provision was at all levels. Additionally, this piece also goes back to knowing your community member and ensuring that everybody is getting services. So some studies talked about how they were very aware of those that were more socially isolated, low SES, the lack of access to technology, those of different cultural backgrounds are unable or speaking different language, and ensuring that any services were being provided to ensure everybody was getting access to that information equally. Before I end, I just want to say a thank you to South Florida Institute on Aging, our community partner, NACOA Psychology Training Cohort of 2020 and 2021. We started our practicum and training in the height of COVID. It was very challenging, but we did it, and we provided some great services to some great people. And also Dr. Ashley Stripling, who is the clinical director of NACOA and my main chair for my dissertation, as well as Dr. Emily Georgia, who is my second chair for dissertation. Any questions? Yeah, go ahead. Thank you. Oh,
Can you all hear me now? So thank you so much for this talk. I love community participatory research. I had a couple of questions about how did you decide to partner with Sophia as your community partner? And it sounded like a lot of what was being done was educating the volunteers of Sophia. Was there any expectation that they would continue to disseminate the information as champions in the community that they lived in or things like that? And then this is a bit of a personal question because I'm originally from Florida. I know there was a lot of controversy about COVID during COVID. And I'm just wondering, did you have to navigate any controversies when you were providing education about COVID? And if so, how did you do that?
perfect. No, those are great questions. So first, with how we ended up partnering with Sophia was, again, we had already before my time at NACOA, we had already a great relationship with previous projects we had done with them. So we already had that connection already, which is really great. We learned how, in all truth, of how this project initially started. We had low census at the height of COVID. We were transitioning our services to being online within NACOA. And part of this was to implement how can we create a community outreach, which is something that I was very passionate about, as well as how can we create more touch points for psychological service and support. And so with already having this partnership, being able to reach back out, seeing what do you have needs, are you struggling with anything? And they said, yes, please support us. We went into more detail with that needs assessment, and then we were able to provide support in those areas. As far as I'm trying to remember, second question, can you remind me, Dr. Fair? Yeah, so community members were not only older adults that were receiving services, but also volunteers that were working with older adults and disabilities within South Florida. So while we were providing this support to them and this knowledge to them, we tried to get their experiences, whether it was personal, oh my gosh, my son goes through that, or my kids or my friends, I've noticed this cognitive change in my partner. So within their own smaller circle, but also with other members, older adults, those with disabilities that they were providing volunteerism and support to, and being able to make that connection. Because that was one piece that the director had mentioned within our needs assessment, that volunteers were noticing changes in those that they supported, but they weren't really sure, is this cognitive decline? Is this mood? What's going on? So part of that knowledge was to help them not only in their personal lives, but also to hopefully be disseminated or create some understanding for those that they supported in the community. And then the other piece around South Florida, height of COVID, very interesting time. From the talks around COVID, what we ended up doing is we brought in medical teams to talk about COVID-19 and to talk about the vaccine when that came out, and about telemedicine as well. And so we made sure that we didn't have as much pushback, I think, because we kind of got it from a medical focus and viewpoint versus a psychological viewpoint, and we provided support in that area. But luckily, we had a pretty tame crowd, so there wasn't a lot of pushback there. But I do think that having a medical individual and personnel from their perspective coming in explaining COVID was really beneficial.
All right. I was involved in somewhat similar work around educating nursing home staff during the COVID pandemic. And one of the things that we saw but didn't capture is that just having education sessions around dementia, around COVID was like exceptionally therapeutic. Like we got informal feedback that the nurses were like, we're just so glad we get to talk to someone about what we're going through. Good God. Do you have any advice if we are providing education in times of crisis or times of huge need, advice for how to capture that better to demonstrate that other layer of efficacy for outreach programs?
Yeah, no, I think that's really important, especially because as providers, right, we provided psychoeducation to not only volunteers and members, but also the staff and the directors within the organization. And so I think in those times of crisis, when you are providing that education, being able to not only give the information, but then just kind of sit with, what's it like to talk about that? Like, what's it like to get this information? And is this helpful? And I think that's where that piece of, oh my God, yes, just I'm noticing these things, but I wasn't quite sure that I have the space to talk about it and get more and kind of make more connections. So then I'm not feeling like I'm going crazy when I'm seeing these things, kind of checking in with them afterwards of not only providing the information, but just that process piece of this was, something you had questions about, you weren't quite sure. This is a really stressful time. What is it like to have this space to do that in?
Brittany, thank you for your presentation and for sharing your work with us. My question is in reflecting on the CBPR principle about trying to build both relationships and programs that will be sustained and make a lasting impact. Do you know if any of the programs, especially the educational programming, has been sustained and carried on by other trainees?
Yeah, so when I was building this presentation, I had to look back through my emails to see where did we go from here? Because I know with my hands-ons with it, it did end in the fall of 2021 as I moved to my next practicum rotation. But I did try to create partnerships between the new NACOA cohort and the organization was in Sophia. From what I understand, it's been a couple of years since I've been in that organization. It's not as robust, but I know that they are very aware that that partnership is still there. There is good relationships and what the work that we did prior to HAPPE-SoFLo, work that we did within HAPPE-SoFLo. So there is the hope that that connection is still there and that it can be built up again. I just think that there's been a lot of shifts within the organization of Sophia itself. And then with the rotation of cohorts every year within NACOA, it's hard to kind of maintain the same level each time as the people and cohorts change. So hopefully the connection is still there, but the robustness of the psychoeducational talks, hopefully they can keep kicking that up again as time goes on.
I think we have time for one more question.
Brittany, I was so excited when you talked about your tele neuropsych evals, and then it didn't really take off. Do you think it's scalable? It would be so valuable, but if it's not scalable, then we should probably acknowledge that.
As far as being able to be more robust, I think that it could be. As I talked about in the barriers and limitations, I think when we hear about assessment, when we hear about cognitive screenings and mood screenings, and then their information was being shared with us, they didn't have a face to a name or a face to a service. And so I think that served as a huge barrier and a limitation for us. We didn't think it would. And then when time had passed and we did reach out, a lot of them weren't interested anymore. They didn't have that connection. So I think it could be scalable. It would just have to be done properly where there was that connection and that comfort to dispel any myths that could be happening of what are these mood screeners, what are these cognitive screeners. Creating that comfort could help with that scalability piece. Yeah.
Via
It was
tele.
doable, absolutely. Yeah, we made sure that the battery was sustainable enough to be done over the phone or done over Zoom, and that we could provide, again, screening results just so if there were any areas of concern, we could refer them to services that would be beneficial. It was just we got in our own way in that area. And so I think taking that into consideration for any future directions or trying to replicate this again. Yeah.
Thank you so much, Brittany.
Absolutely. Awesome. Thank you all. Appreciate it.